So, good morning, everybody. Welcome to the Health Overview and Scrutiny Committee. Welcome to committee members and the Health Trust representatives, and also to the public that might be watching. Right, first of all, I'm going to go to apologies for absence. So, Joe, could you just update us on where we are?
Good morning, everyone. We have apologies this morning from Councillor Paul Hodgkinson, and we welcome Councillor Bernie Fisher to the meeting, who will represent Paul at the meeting. We also have received apologies from Councillor Helen Molyneux, and they're the only apologies I've received so far, Chairman. Could I just remind everyone to mute their microphones when they're not speaking at the meeting? Otherwise, we will get some background noise. Thank you.
Yes, thank you, Joe. We have a facility where you can raise your hand if you wish to speak. So I will be looking to see if people have their hands raised and try and bring people in at the right time in the order in which they've raised their hands. But if that doesn't seem to be working, by all means, wave your hand in front of the screen to get my attention, or failing that, do intervene. But we should be able to do it in a fairly orderly fashion. So the next step we're going to go to is to just see if there's any declarations about interest from anybody. Anybody wish to declare an interest? Can't see anything, so I'll take that as a no. So that brings us then on to the minutes of the last meeting. Are there any questions or corrections that people wish to make to the minutes? Can't see anybody indicating that they want that to do that. So we'll take that. I'll take it that the minutes are accepted if nobody expresses any opposing view. So I'll take that as the minutes are accepted, and we'll move on then to the first item on our agenda today, which is a public representation. And I'm going to ask John Thurston, who's joined the meeting from Lydney, to now make his representation. So, John, if you'd like to unmute and make your presentation.
I think I'm unmuted.
Yes, we can hear you.
Thank you very much, Chairman. I'm sorry I'm a little bit improvised because I couldn't set this up all of a sudden on my PC. I've had to use an iPad. Welcome. Thank you very much for allowing me to put this question forward. Our question does not apply to the provision of inpatient service beds in the Forest of Dean, but to the loss of the other local services in the South Forest if the Lydney Hospital is completely closed. In recent years, and actually from the foundation of the hospital 132 years ago, outpatients and urgent care visits to Lydney are many times the number of the inpatient visits and are most highly valued aspects of the local provision. We haven't had long to read through the consultation, so we've not been able to digest all the papers, but we are pleased to see that there is an acknowledgement of the representations that we've been made that there will be a loss of services. And we do welcome the opportunity to partake in a constructive working group. However, presently, we can see no commitment that funding will be made available to provide those services or that they're considered necessary. There must be funding, money savings from the closure of Lydney Hospital, and some of those monies we feel should be used towards providing those services lost to our community. Knowing the current resource, buildings and people, we see no evidence that there is an ability to provide and fund such a provision, despite the plans to close the existing hospital. We were encouraged to support the case for a single hospital with inpatient beds for the 3 towns, on the understanding that comprehensive health provision will be made in the other 2 towns. Lydney in the South Forest is the largest and fastest growing area of the Forest of Dean. As you all know, or many of you will know, transport and travel are not good, and many people live out or on the 30-minute travel time from Cinderford. The passenger miles will substantially increase with an inconvenience without a local health hub. Our aspiration, and it's good to have aspirations, is to replace the lost services and others in a new, innovative 21st century facility. We're now in an ever increasingly 365/7 24-hour society, expecting immediate response, and those in rural areas have an equal right to partake. It may not always be possible, but we should get close to it. Over many years, we've had good provision in Lydney and do not wish to be disadvantaged. The Friends of Lydney and District Hospital are prepared to offer support to new services in Lydney, as we have done for the last 100 years. Thank you for this opportunity. Very pleased to answer any questions.
Thank you, John. That's very clear. I think I'm going to go to, is it Ellen? Are you going to respond to this? Yeah, so we'll have a response from Ellen on from the Health Trust. Thank you.
Hi, Ellen.
Hi, John. How are you?
Hi, Ellen.
Nice
Well,
to see
I'm fine, and thanks for the conversations we have had.
John, I have discussed this. I was going to say we have had a number of conversations on this front, and can't hear me. Is that coming across to everybody?
You might need to switch your video off to get.
Can people hear me okay? Okay, sorry about this. Thought it seemed to be working okay. Can you hear me now? Is that better?
Much better.
Okay, I'll keep the video off for now. Okay.
Can hear you fine.
Okay, well, I'll keep the video off for a moment. So yes, I welcome John's points, and as he said, we have made an acknowledgement of the conversations we've had in the document we've put forward today. So the focus of this consultation is on the services to be contained in the new single hospital. And there has been significant previous engagement and consultation that's led us to the point that we're at now, to consolidate the two hospitals into a single site, and that the location of that facility will be Cinderford. We have heard the feedback through a number of the phases that we've been through. Residents in the south of the Forest have this concern that John has so clearly outlined this morning. So alongside the consultation, which as I've described is concentrated on the services for the hospital that we need to get on and build now, we have proposed we convene a working group to continue to work on the service provision in the south of the Forest. Obviously, of course, any proposals have to meet our requirements around deliverability, sustainability and impact to other service provision. However, we do feel, as we do now, that there is opportunity to deliver outpatient services and so on within the health centre facilities that we would put in Lydney, as we do already now, and as we plan to do in Cinderford and also in Colford in the health centres there. So I do feel there is scope to plan and propose a service model that would be a positive step forward for residents in the south of the Forest. So our aspiration is that the working group will be representative of people who live in the south of Forest, but also have health and social care professionals to represent the range of services that we would discuss there. We've used this model already through the locality reference group, and I think it's worked well. Obviously, recognising the particular circumstance we're in at the moment, we also anticipate using some surveys, some virtual means like this, using MS Teams and so on, because we're unlikely to be able to do face-to-face workshops, but we think there's a way through that. I should also note that the CCG is in discussion with local general practice providers in Lydney, and we are committed to the development of a business case for a new health centre within the south locality. But we do need to work through and agree a clear direction and a solution with the general practice providers in that area. Happy to take any further questions, but that's our formal response to the important points raised by John.
Thank you, Ellen. I'll go back first to John just to check that you've had a reassurance there, and whether you want to, I don't want to get into a big debate, but whether you feel that that assurance is satisfactory, or whether you've got any quick concerns you want to pick up.
I do have a concern that the hospital seems to be more advanced than anything happening in Lydney. And I would like the assurance that the services are maintained in the existing Lydney hospital until a new health centre is up and running in Lydney. Because at the moment, I can see there is a big divergence in time plans.
Yes, and I think probably what you're also looking for is a time plan for Lydney that coordinates closely with any opening of a new hospital.
Yes, well, it's also a time plan that we don't close Lydney Hospital or reduce the services there until we've got the replacement services back in Lydney. I mean, the existing site is not suitable. Clearly, they've got to do a lot of work to be able to get it. I understand doctors have to actually underwrite the building of new buildings with any third-party providers. And at the moment, in the One Lydney practice, there's only one partner there at all. Others have left. I know there's some help coming in from other areas, but there's no understanding that help is going to provide the underwriting necessary to provide the new buildings that are necessary. They are very, very short of space at the present time. Currently, we've been providing tented facility for the practice outside because there's no space to go in the practice to actually receive treatments.
Okay, thank you, John. I think we've clearly heard that as a committee. You've had a response. Ellen, do you want to come back on any of those points, or are you just going to take the concerns away?
Yeah, I can't. I mean, obviously, John knows I can't give assurances on things like buildings and capital schemes with planners and building companies that we haven't signed off yet. So he knows that I can't give that assurance today.
I know your problems.
Yes. So, but we do hope. What I could commit to, I think, is that again, John knows some of the further details that we're working through. And I know he also knows local people and has some good information about what's happening in the practices. So I think he'll understand when I say that I think we could come back with a firmer plan, probably quite early in the new year. I'd like to say January, February might be slightly safer, but somewhere around that time, I think that we will be able to give a much clearer plan of the way forward for Lydney. And I think it would be good for the committee to hear about that at the point when we can share it in a bit more detail.
Okay, thank you, Ellen. Thank you, John. I think that gives us a clear points made and a response there. So the committee won't get into discussing this, but obviously may do in the future if it needs to come back to us. So thank you very much, John, for bringing it to our attention.
And thank you for the opportunity to put it forward. And I thank Ellen and others for the communications I've been able to have so far, but the public doesn't see any of it. Thank you.
Thank you, John.
Bye-bye.
Right, we're now going to move on as a committee to our first of our main items today, which is the Fit for the Future proposals for changes to the how we deliver services in the Gloucestershire. So I think for that we're going to go back to Ellen, who's going to present that report. So we'll go back to Ellen. Thank you.
And could we just wait until John's left the meeting? I think John's going to leave the meeting now and view the meeting by YouTube. There he is.
Right, okay. I think he's gone now, actually, hasn't he? So.
Thanks, Ryan. Shall I begin?
Yes.
Yes. We're going to do a bit of a shared presentation here. So I'm going to take you and the members through the covering paper. Then I'm going to hand over to my colleague, Simon Lansley, who's got a presentation. And we'd also like to show you a short video, if we can keep everything crossed that the technology will work. So Mickey Griffiths, another colleague of ours, is standing by to screen share some of the presentation and hopefully the video as well. So we'll take it in those three parts, if that's okay, Brian. So starting with the covering paper that we've shared with you.
Before
sure.
Steve, you've got your hand up. Do you want to say something right at the beginning, or are you just getting in first?
Really be guided by you, Chair, but as I emailed you last night, or sorry, this morning, I don't know when we cover it, so I'll regard it by you, but I think there is a whole issue of principle about what our role and function is here today on this topic. So,
okay. I
wait till
will take on board what you're saying, but I think what we'll do is have the presentation because that does
okay. No, that's
pick
right.
up
Regard it by
that,
you. Yeah.
and then we'll come back to your question.
Okay,
We'll carry on for now.
shall I carry on? Okay, so obviously today we're here to talk to you about the really important next steps in our Fit for the Future programme, because we believe that this represents a substantial variation and development of health services in line with our memorandum of understanding that we have between us. The committee is obviously well cited on this programme and has been informed through the regular updates that have actually gone on over several years now, and notably the output of the earlier public engagement, which has facilitated the development of the potential solutions for change that we're putting forward today to share with you, which are now ready for public consultation. We've provided to you the supporting materials that go alongside the consultation. So the consultation booklet and materials have been provided to you. And we're going to share the details of the proposals as I've outlined today via the presentation and the short video that we're going to share with you. This is a joint programme which has been developed between all of the ICS partners in Gloucestershire. As I say, we are going to talk about, I think in a minute, as part of the presentation as well, the concerns that you have raised to us about the timing of the consultation, our response and proposed mitigations. So moving on through the paper to the programme vision and what we're intending to do. So this is part of our ongoing development of our two-site acute hospital in Gloucestershire. So we have been thinking about how to best use the advantages that being a two-site hospital offer us. And we've described this as our centres of excellence for hospital-based care. And it means that when patients have a serious injury or illness that requires specialist care, we can provide the best outcomes and experience. As we've talked about with you before, because this is focused on specialist care, there are no changes proposed to outpatients, day surgery and A&E, so effectively the front door services. And so the majority of those front door access services are delivered locally, so closer to home, and centralising where we believe it will improve health outcomes and make the best use of our scarce resources, such as specialist staff and equipment. So, and just important to say at the outset that we aim to maximise the two sites with a focus on planned care through one site and a focus on emergency care through the other. But this is not proposing a full separation of emergency and planned care. So the clinical model does retain a 24/7 emergency department at Gloucester Royal and at Cheltenham General with the nurse-led unit overnight as we have currently. And 24/7 intensive treatment units on both sites. The other significant advantage that we feel this configuration improvement will bring is that patients and families who currently have to travel out of our county will in the future be able to be treated in the county as we develop our service model here. So why do we think change is needed? That's an important part of any consultation, is to set out that case for change. So going back quite a number of years now to 2002, we actually merged the two hospitals, which were two separate trusts in Gloucestershire, to form a single trust. Since then, a number of services have been centralised to one or two sites. So to give some examples, paediatrics, gynaecology, and also some of the model changes that we have in place as pilots at the moment, such as trauma and orthopaedics, and also the concentration of oncology services at Cheltenham General. Many services and specialties continue to be delivered on both sites, but increasingly this creates pressure for workforce, and quality and safety becomes potentially compromised as we become stretched to cope with increasing demand. It's also true that as medicine has become more specialist and requires more technical equipment, to put it simply, that it's difficult to purchase and provide that in 2 places when we could do so in 1. In order to develop the proposals, this has been a very long-running programme. We have worked with extensive public engagement to inform the proposals, and equality, travel impact assessments, so on and so forth, all the things that you would expect us to do to develop service proposals of this nature. We did extensive preparatory work. We then developed a long list, which were focused on the 3 clinical work streams in this consultation, so image-guided interventional surgery, general surgery, and emergency and acute medicine. We then, at the next stage, applied what are called hurdle criteria, which is effectively saying if a solution is non-deliverable, so it's just unaffordable, or you couldn't deliver it for some other reason, like you don't have the building space or something, then those long list solutions get knocked out. Or, for example, if the clinical adjacencies wouldn't work. We then grouped our options into clinically viable models, and then identified some meaningfully distinct options. So when we did the first long list and all the possible variations, there were just hundreds of possible variations that you could have. We then consolidated, by the time we'd got through the clinical viable models, we still had 29 possible variants, which is clearly far too many to take out to a consultation or to work through in the level of detail that we need to work up. So we formed a medium list of options where there was significant difference to make those meaningfully distinctive options. And 8 were then taken forward for evaluation at a solutions appraisal workshop. The solutions appraisal workshop, we believe, was a first and quite an innovative approach to the solutions appraisal process. So typically solutions appraisal is done by a reasonably small group of people. We took a very large group of people that was multidisciplinary and involved members of the public. And we held that over 2 days, and we had very extensive input into the development of those preferred options. What we landed on is a number of preferred options that we wish to now take forward to public consultation. And we also reviewed the 2 pilot reconfigurations that committee is aware of, so gastroenterology and trauma and orthopaedics at these workshops. Having reached the point of the preferred options and configuration that we wanted to put forward to public consultation, we then took that through the South West Clinical Senate, which is an independent clinical body who reviewed our proposals, and then they actually did suggest some small adjustments, in particular around some of the options that we were going to take forward and our choices around those. And the report of the findings from there was a key element of the assurance process with our regulators in relation to Test 3, which is about the clinical appropriateness of the proposed change. And so, as I say, at that stage, there was a small change to our shortlist proposal. And then following that, we received a statement of assurance on the programme on the 7th of October 2020. So what I've described there is the development of the clinical options. There are also a number of other components of the assurance that our regulators undertake when they look at our proposals of this nature. So the first test relates to strong public and patient engagement and stakeholder engagement. And our regulators found us to be fully assured on this point. So they looked both at our historic level of patient and public engagement. And I've mentioned the solutions appraisal workshop. I should have probably also mentioned the citizens jury that we held as part of the engagement. And as I've mentioned, the extensive engagement we undertook. They did also look at our prospective plans, and I know this is a particular point of interest to the committee. So they examined our plans with regards to our socially distanced consultation, our proposals for the consultation, and our plans in terms of how we intend to deliver the consultation. That was also supported by independent advice from the Consultation Institute and our regulators found us to be fully assured and our plans to be sound. And indeed, I know the committee wants to talk further about this, but we are not the only area in the South West going to consultation at this time. Indeed, there's a consultation live in Devon. And we were able to look at and share best practice with our colleagues across the region on that front. The next test looks at consistency with the current and prospective need for patient choice. And we again were fully assured on this point. So in this space, we considered issues around where a specialty was moving to one site, how that was mitigated by the maintenance of outpatient services on both sites, where the majority, of course, of the footfall from patients would be, and also the offer to relocate services where currently patients are having to travel to Bristol or Oxfordshire or Birmingham, for example, and we would be in future able to provide that within Gloucestershire. I've mentioned test 3, the clear clinical evidence base and the Senate review. And then test 4 is around support from clinical commissioners. So these are other commissioners around our borders. So we've had letters of support from example, Worcestershire, Warwickshire, Bristol, Oxfordshire, and Ayr and Bevan in Wales, and so on and so forth. The next point is around the NHS bed test. It's not applicable to Fit for the Future as there's no bed reductions in our plan. And then we were fully assured around our financial assurance of the plan, so that the business case is not causing a cost to our system, and our implementation plan in terms of at the end of this, do we have plans about how we could implement the model? So that was quite a detailed section of the paper, but just to summarise then, we have undertaken a really comprehensive incremental process to develop these options over a couple of years now. And our proposals have had full external review and assurance, but these options remain subject now to this final stage of public consultation. So moving on, and you'll hear a lot more from Simon on this, I'm going to keep my part of this relatively brief, but what are the proposed options? So the fixed proposals that are common to all of the models we've put forward are to formalise the configuration of trauma and orthopaedics that we currently have live as a pilot, formalise the reconfiguration of gastroenterology, also currently as a pilot, retain the current configuration of planned upper GI surgery, which is centralised at GRH, centralise the acute medical take to GRH, centralise emergency general surgery to GRH, and general surgery day cases to CGH. Develop a 24/7 image-guided interventional surgery, or IGIS hub, and vascular surgery to GRH, but with an IGIS spoke at CGH. And this is particularly around developing highly technical specialist equipment to deliver a range of cutting-edge medical procedures that currently have to be done outside of our county. And then to support the changes above to establish an enhanced deteriorating patient model. That's a slightly unfortunate term, isn't it? Because nobody would want to be deteriorating, but effectively severely unwell, delivered by an acute care response and intensive treatment unit teams across Cheltenham General. There is a variable option remaining around the centralisation of planned colorectal services, which could be centralised to either Cheltenham General or to Gloucester Royal. And there's a case to be made for either, and we propose to put that forward in the public consultation as well. So moving on to the consultation approach and timeline, we do believe that consultation is required at this time, given the substantial nature of the proposals, and we've shared the strategy, plan, and the consultation materials and so on in more detail with you. We have a legal duty to consult, and we have statutory guidance that sets out how we should do that. There's a number of toolkits that support the approach that we should take, including planning, assuring and delivering service change for patients, which is published by NHS England. And it sets out this and some further guidance sets out when we should decide to consult the public. And I won't go through this in detail, but we believe that these conditions are met, and we have gone through the assurance process with that in mind. In terms of obviously you as a health overview and scrutiny committee are a key partners that we consult with as part of this process. And we have thought carefully about the points you've put forward to us regarding consulting during a pandemic, and I'm sure we'll talk further about it. And I have set out the very valid issues and concerns I feel were raised. I hope I've summarised those to your understanding as well, and then set out some responses. So I'll summarise it as follows. So we do feel that the risks of pausing do now outweigh the risks of proceeding. As I've outlined, a number of services currently are operating under temporary change agreements, and I do believe this situation does perpetuate uncertainty for staff, but also for the public. We don't believe that consulting puts any of our service delivery at risk. Staff who run our consultations processes are not directly engaged in service delivery. Of course, a small amount of clinical time will be used to support the process, but it will be outside of patient contact hours for those staff who are involved. And typically those who do come forward to support this type of work also have management responsibilities factored into their day jobs. We do recognise that people are busy and may find it hard to focus on the issues set out in this consultation. And we hope to be able to overcome it by offering a comprehensive range of materials, many different opportunities to contribute, including online and face-to-face, and also sending mail shots to people's homes. And also we do feel that if people do want to talk to us about their COVID experiences during this process, that this will also be informative to our future planning and delivery of services where COVID is, I feel, inevitably part of our new normal. And we will collect that feedback and use it as part of our future planning for services. And finally, with regards to the other point that I feel has been well made about future-proofing, we do believe these are the right proposals for development of our hospital services, whether or not COVID is circulating at high or low levels. And we want to firm up permanent arrangements to give certainty to our staff and the public. I think it has been evident that uncertainty over the previous period has at times led to speculation in the media and on social media about which services are likely to be subject to change due to the anticipated consultation, obviously particularly around Cheltenham A&E. And this has caused significant concern at times for staff and local residents, and so we do not believe that perpetuating this uncertainty is in the best interests of either group. And we do believe we have tested our proposals against a number of future scenarios, and in all cases, the proposals do remain valid. Obviously, when we reach the end of this consultation period, it is absolutely within the committee's gift to make a Secretary of State referral where if you feel that the consultation has not been adequate. And we absolutely respect your right to do this in this regard. But we do hope you will have taken account of the fact that we have considered your advice very carefully. And of course, we will keep in regular communication through the period of the consultation with you. In terms of the wider context, I just set out a little bit here to just remind again, there is some overlap between our proposals now and the temporary service changes. And we do absolutely recognise that's complex. And we feel we have clearly communicated that in the consultation materials provided. But obviously welcome your thoughts on that matter as well. We've included then section 4.2, a further piece at your request regarding the confirmation of the approach to the restoration of Cheltenham A&E to its pre-temporary change state, which we anticipate would be happening in March. And we've set out just a table here about the conditions that we feel would need to be met to do that. So in terms of the next steps, we've set out the proposals for the Fit for the Future programme. We understand the concerns that exist, and I hope we have demonstrated we are extremely mindful of those concerns. What I'm going to do now is to hand over to Simon, who will provide you with a bit more of the specific detail of the clinical changes that we propose. And we have some clinical colleagues also here in the meeting who will be able to answer any questions that you have on that front. And as I said, we will also show you a short video at this stage.
Great, thanks, Ellen. And Mickey is kindly driving the slides for me. And Mickey, I think we're going to kick off with the videos. If you could bring that up first, please.
Our ambition is to provide world-class, leading-edge specialist hospital care for our patients. Our expectations of healthcare, the demands on...
Sorry, Mickey, we can hear it, but we can't see it.
I certainly could see it. I can see it, and I see what you mean. We can't see the video. We can just see the
video.
No, I couldn't see it.
I could see it.
Can't see it.
I think you'll find it in a sec. I think he just has to share a different window, that's all.
Yeah, we can see a different window now, so it may well... It's not running.
Hopefully it'll start. That is one thing with these virtual things, it is...
Our ambition is to provide world-class, leading-edge specialist hospital care for our patients. Our expectations of healthcare, the demands on the health services, and the incredible progress made through science and technology have dramatically changed the environment that we're operating in. This means that we need to do some things differently. Thanks to the great work of NHS and care staff, we're well on the road to outstanding, but there's more to do. That's why we've been involving staff, patients, local people and the public in looking at a number of services and potential solutions. Following extensive engagement with staff, partners and the public, which included a citizens' jury and a solutions appraisal in public, we're now preparing to consult on a number of options for some services across our sites. We will use a variety of methods and approaches, including a virtual online consultation. The aim is to improve health outcomes, reduce waiting times and the number of cancelled operations, and ensure people see the right specialist to meet their needs 24 hours a day, 7 days a week. It's important that there are always strong and safe staffing levels across our services. We support joint working between related services to reduce the number of visits people have to make to hospital, and we attract and keep the best staff in Gloucestershire. For our services, it's about developing our Centres of Excellence approach, which reflects the way a number of services are already concentrated in one place, such as cancer care in Cheltenham and children's services in Gloucester. For our hospitals, it's about developing to 2 thriving, vibrant district general hospital sites in Cheltenham and Gloucester, with strong identities, both providing world-class leading-edge treatment. The potential solutions we outline in Fit for the Future consider whether one hospital should focus more on emergency care and one hospital should focus more on planned care and oncology. We believe this could help to ensure that the right facilities and specialist staff are always available to give people the best treatment and care. It could reduce the number of planned operations cancelled when beds or operating theatres are needed for the most urgently unwell patients. We want to strike the right, but often difficult balance between having 2 world-class centres of excellence in Gloucestershire and providing local access to services. There are no proposals to close Cheltenham A&E or to change the current staff arrangement, which includes consultants, doctors, nurses and allied health professionals. Full facilities for resuscitating, stabilising and treating patients would continue to be in place. Last year, we ran a comprehensive programme of engagement, and together with you, we explored the opportunities and challenges of developing specialist hospital services. We developed ideas and potential solutions for change and designed the criteria we would use to assess those potential solutions. We now want to consult with you about how we could organise some specialist services. Acute medicine, gastroenterology inpatient services, general surgery, which means emergency general surgery, planned lower gastrointestinal or colorectal surgery, and planned day case surgery. Image-guided interventional surgery, sometimes called IGIS, including vascular surgery, and trauma and orthopaedic inpatient services. For more information, please visit onegloucestershire.net or register with our new engagement platform, where you can share your views, experiences and ideas about health and care services at getinvolved.glos.nhs.uk.
Great, thanks, Mickey. I just wanted to pull out a few points of that video, starting with the vision, really, which is around this specialist hospital we're operating out of 2 campuses, so one in Cheltenham and one in Gloucester. And this is really about turning the strategic objectives of the NHS long-term plan into action. So members will be aware that we have centralised some services onto a single site, and Ellen mentioned paediatrics to GRH and oncology to Cheltenham, and there are others. But in most cases, the configuration of services across our hospitals is down to history rather than design. So this Centres of Excellence model is about setting a longer term strategy for how we go and continue to use those 2 sites. Really important to note that this is not a purist model. So what we're not saying is it's not all emergency to Gloucestershire Royal and not all planned care to GRH, to CGH, but it's about a greater focus. So the greater separation of emergency and planned care to Cheltenham General, and more emergency surgery and activity to Gloucestershire Royal. But it's, as I said, not a purist model, and you see that with our commitment to Cheltenham General Accident and Emergency, which will remain a consultant-led unit from 8 AM till 8 PM and a nurse-led unit from 8 PM to 8 AM as it was pre-COVID, and also in our commitment to maintaining 2 24/7 critical care units, particularly at Cheltenham General, to support the level and complexity of elective care that we would like to deliver from that site. Next slide, please, Nikki. So I just thought it would be helpful to just explain in a bit more detail what we mean by a centre of excellence. So you see some of the key points on screen there, but to try and bring it to life. So for an emergency centre of excellence, it's about treating patients with life or limb-threatening conditions on a single site, so that when they arrive, they have the right specialist team available 24/7. So the facilities are there, the equipment's there, and services are co-located. So we can provide a rapid senior assessment, we stabilise the patient, we agree the treatment plan, and we get the best chances of survival and recovery. We also think under this model that we can repatriate activity that's currently going out of county. So patients sometimes overnight and also in the day are being sent to Bristol, Oxford and Birmingham. And by centralising emergency services onto a single site, gives us greater spread of a workforce cover, means we can bring those patients back into Gloucestershire and they get treated in Gloucestershire. And in terms of planned care, separating those services from the sort of competition that you get for emergency, so it removes that competition for beds, for theatres and for access to diagnostics, which means that we can reduce the level of cancellation. So particularly in peak areas of activity, sometimes our planned patients can get cancelled because the emergency volume is so high. By separating that, we can give reliable access to planned care. So we can plan on the basis that our theatre lists will run all year and they will start on time. We'll have access to the right equipment. The ways of working will be informed by best practice. So, for example, greater levels of research and robotic surgery on the planned care site. And Cheltenham will all be geared up for that rapid pre and post-operation recovery and support. Next slide, please. I mentioned the vision is around sort of bringing the NHS long-term plan into action. But I wanted to share that there's a load of guidance and research and policy and best practice that has informed our proposals. So you'll see there evidence from Royal Colleges, from NHS England, from national programmes such as Getting It Right First Time, and also really significant support and insight and challenge from South West Clinical Senate. So a group of clinicians from outside of Gloucestershire whose role was to check that we were adhering to national guidance and best practice and to provide advice and support for some of our proposals, of which we've incorporated. So particularly advice they provided around the configuration of vascular surgery, we have incorporated into our plans. And importantly, they have confirmed that our plans are deliverable and safe. You'll also see there strong feedback from the public and staff engagement process, so listening to what patients and staff felt was important, and that helped inform our shortlist. And for example, particular push from residents around the ability to repatriate activity back into Gloucestershire. Next slide, please, Mickey. So this is where that work comes together. So the outcome of all the engagement process, the regulatory process we've been through, and that external challenge. And then you see a greater focus of emergency care at Gloucestershire Royal and a greater focus on planned care at Cheltenham General, but as I said, not exclusively. The services in red are where we've had a preferred option. So you can see the ones there that we're proposing to be on the Centre of Excellence for emergency care, and those services on the Centre of Excellence for planned care. And the two in blue at the bottom is where we have an option. So both really exciting and innovative models of care, and both are deliverable. So in one option, you would have colorectal surgery on the Centre of Excellence for emergency care alongside emergency general surgery and upper GI. And in another option, you could have planned care for colorectal services alongside urology, gastroenterology and gynae oncology to perform a pelvic resection centre. So both models are really different and innovative and deliverable, and we will keen to get the views from the public on that we will then take into our final decision making. Next slide, please, Vicky. So Ellen touched on this, and I hope you're hearing the message loud and clear around Cheltenham A&E about reverting to the pre-COVID opening hours, so consultant-led in hours and nurse-led from 8 p.m. to 8 a.m. Important to note that there's some crossover between the temporary service changes, but this is for the future is all about the medium and longer term strategic options for the two sites. If we get the strategy clear, then we can move on to planning and operationalising those changes. Next slide, please. So the last two slides are around who are we consulting. So you can see that the various groups listed there. The key bit here for us is to listen and understand. So listen to understand what people are saying, that we can then take that on into our decision making into March. And I think on the final slide, Mickey, we list some of the various ways that we're looking to do that. So support from the Consultation Institute throughout the process to make sure we're following best practice. And then consulting in a pandemic, we've increased and broadened the range of methods for people to get involved in the consultation. The film that you've just seen is one of many films that we've developed to help explain the changes, and we'll use those online and in groups. Telephone interviews with some of our protected characteristic groups, for example, a broad range of staff events, and then the traditional booklets that you're used to seeing with online surveys. So I think I'll pause there, Brian, and hand back for open up for questions.
Yes, thank you, Simon, and thank you, Ellen. I mean, I think that's a very clear explanation of the changes you're proposing to go out for consultation on. I'll just have a look to see who's indicating they'd like to ask a question at the moment. I can't see any hands up at the... I can see Martin Hallwood as is waving at me. So we'll go to Martin and take his question first.
Well, I was actually going to suggest that perhaps we go to Stephen Liddon first, who raised an issue at the beginning of the meeting about what we're actually being asked to consider.
Yeah, okay.
Because it is noticeable that in the local media, the consultation appears to be already launched.
I think the consultation would actually start today.
But it's been announced in the local media before this meeting. But Councillor Liddon had a point to make on this, I think.
I'm happy to take Steve's question as well first. Steve, are you there? You're still on mute, Steve, so maybe
Just
that's
take
why we
some time
can't.
to work through it. Is it my go, yeah?
That's it. I can hear you now.
Right, thank you, Martin. And it's Leiden, Martin, but don't worry, I'm used to getting me
That's
name.
all right.
Don't worry. I mean, I don't want to go on about this, but some of the arguments, I'm not a clinician, and they're obviously very honourable and very respectable, and lots of work have gone into them. But I actually think the overriding concern is that A, I don't think this will get a fair hearing. B, we risk complicating the messaging that we are supposed to be working on in terms of COVID-19. We know the figures are increasing. I know this is live, and I don't want to be accused of panic spreading, but we know we need to be planning ahead for further increases, and we need to get the messaging right, and we're looking to take actions locally and county-wide to do that. And certainly when I've discussed this locally with people, I'm not being funny, the reaction I get is we must be bloody mad to consider doing this now. We risk, I think personally, it's completely the wrong time to do this. You won't get a fair response. If anything, you may be accused of trying to slip it through in times of a crisis. I also believe that we need to check out formally from GCC legal department, which I certainly did before when we faced a conundrum like this when I was chair, what the formal legal position is and what we can do and what we can't do. I mean, and the word consultation, and many of us involved in planning know this, sometimes it's asking, sometimes it's telling, sometimes it's listening. And I get very confused on occasions like this what our actual role is. Are we listening? Are we telling? Are we asking? Are we just auditing the process? Because I generally think this is the wrong time and the wrong place to be actually doing this work. And I respect that Ellen has tried to, and others have tried to allay those fears in the work they've done. But nothing has as yet convinced me, and certainly other colleagues, and I've discussed it locally, that this is the right time and the right place to do all this. And I would seriously counsel, without having to go through the legalese, we pause this. I'll rest my case there, Chair.
Thank you, Steve. Before I bring somebody to answer, can I just push you a little bit, because what I think you're saying is not that these changes aren't the things we should be doing, and it shouldn't go to the public for them to feed back on through the consultation, but you're saying that to do that at the present time would not work. What do you think is it you don't think the consultation would bring a proper response? Or I just wanted to push you a bit. What are the concerns about consulting?
Let me be clear. A, I don't think you get a fair response. I think people's minds ought to and should be on COVID-19. B, I believe that COVID itself, we've admitted locally that we need to give far greater clarity on the messaging that's going out and how we actually look to use enforcement and other measures. And anything related to health risks complicating and confusing that. I also think as well, of course, that we've already said that for the next 6 months, we're only going to have 80% capacity. And I generally feel that going off on things like this, you risk people saying, well, hang on, you're doing all this consultation. I can't get in to see my GP. I can't get my cancer sorted out. I can't get an appointment. What's going on here? So I generally feel I don't disagree with doing a consultation on fit for the future. I just think this is the wrong time to do it.
Okay, thanks, Steve. Let's go back to, I'm not sure if it's Alan. I'll come to you, Martin, in a minute, because, unless you want to raise your question. I think your question is on a similar line. So if you want, should we take your point, Martin, and then we'll go back to Ellen and get an answer? Yeah. I think you're also concerned about the timing, aren't you?
Yes, absolutely. And I'll just echo exactly what Stephen's just said. I mean, these are hugely complex changes that we're being presented with, and they deserve really thorough examination. The last time that the general surgery changes were proposed, they proved very controversial amongst many clinicians, and we took some time to convene meetings of clinicians independently of the trust in which there was huge opposition to these changes. Now, we don't know if that's exactly the same now. The Trust has sort of suggested there is more clinical support this time, but I, for one, would prefer to test that out. The introduction of the centralisation of the acute medical take seems to me quite a major step with implications. I mean, although we're told this has no implications for Cheltenham A&E, that can't be true. If you centralise general surgery and the acute medical take in Gloucester, that has implications not just for Cheltenham A&E, but for Cheltenham Intensive Care. These services are intimately linked and affect each other, and the likelihood of people being able to go to one or the other in terms of staffing seems to be quite a major factor for staff and people being recruited to these services. But also it is about the timing, as Steve said. First of all, we don't know what the new normal is going to look like. We're far from doing that. We're in the middle of a pandemic. We don't know what the pattern of acute and urgent care is going to look like in a year's time. We don't know whether there will be, we hope there will be a vaccine in place, but we don't know how effective it will be. We don't know what the treatments will be. China are starting to build COVID-19 specialist wards and reorganise their services on that basis, but we don't know if that's the right thing to do. We don't have the national and international learning from this pandemic. We don't know what the pattern of recruitment is going to look like. House prices are apparently plummeting in London and rising in Gloucestershire, so it may prove easier to recruit to some of the services that we've have been hard to recruit to in the past. So all of this, it just seems highly likely that if we plan major change now, in a year's time, we'll be looking at modifying it all anyway, because we'll have learned many things from the pandemic. The second thing is, just the two other points, that the second point is that the public engagement is going to be difficult, with possibly changing rules on what you can and can't turn up to, not least, if you wanted to gather people like clinicians together, that might prove difficult under these circumstances. And then finally, as Stephen said, management focus should be absolutely on the pandemic, and not just at the Trust, but on the partner organisations you're expecting to consult, like local councils. They should be focused on support for local people and local business in the pandemic as well. This just seems completely the wrong time, and I think we should withhold our approval of this.
When do you propose that they should go ahead? Are you looking for a 6 months delay, or an indefinite delay until
it is clear that the pandemic is under control and we can sensibly plan for the future?
What if that's 10 years away?
Well, no, but that's not going to be the case. We are going to have some kind of vaccine within a matter of months.
Thanks for your question.
So we're not talking about 10 years, of course not.
We got two clear points there. I'll come back to Ellen on, which is that now is not the time to be doing these changes or to be consulting on them because of other pressing priorities. So can you perhaps respond to that?
Yes, of course. I hope I responded to these points in the paper, but I do agree, obviously, we need to talk them through. We disagree for the reasons we've set out in the paper. So I think it's incredibly difficult. So we have not reached this point lightly, and we did pause the programme earlier in the year. But we're in a very different place now. We know a lot more about COVID-19. We know a lot more about how we're handling the response. We're not in the same position we were in March when we did, we feel, appropriately pause. We feel that we have a much more settled situation now, notwithstanding we recognise that cases are gradually climbing, but we know what we would do with our response. We've already done it, in fact. That's why we put the temporary changes in place. And we believe that makes our position resilient, and that we are able to manage this within our management capacity. Otherwise, we wouldn't be wanting to do it ourselves, because that would clearly not be a sensible thing for any of us to take on. I think the point that Steve makes about the people's feelings at the moment about the NHS and the long waiting lists and access to GPs and so on are very well made. I think that when we go and have conversations with the public, we will, and we do hear about those things a lot. I think that doesn't mean we shouldn't have a conversation about our longer term service direction. And I've set this out in the paper, so at risk of repeating myself, I firmly believe that perpetuating uncertainty does us no favours either. We don't particularly like, in inverted commas, having service change in place under emergency change arrangements or temporary pilot arrangements, a number of which we very much believe are long overdue being consolidated into a permanent arrangement. So I don't believe that perpetuating that uncertainty is good either, and I don't think we have a clear end point at which we could go, well, we're out of the woods on that. And certainly, if you're talking about the issues around the health service and waiting lists and so on, sadly, those problems are not going to be resolved in 6 months or a year or probably 2 years. So at any of those times that we go out and talk to the public, I feel that that conversation will be a feature of the conversation we have with the public about concerns over long waiting times and so on. And that's okay. We can hear that. We can provide some outlet to that. We can signpost people to information about how we are handling that. And maybe actually there's a useful secondary function in being open for a conversation at this point in time. So I hear what's being said and described. I think it's right, but I don't see that as a negative or a reason why we should stop having a conversation about something else that we also believe is important. I think Martin raised a lot of other points about the clinical points of the model, but I would want to hand over to Deborah first on that point about the consultation, because I imagine she would also wish to comment on that.
Thank you, Ellen. Brian, I just wonder whether it wouldn't be most helpful to start with what for me feel like the most fundamental questions, which is what is the role?
Deborah, as you've just appeared for the first time, it'd be useful for the people watching if you just say what your role is. So
yeah,
that people
of course.
No, because obviously we know who you are, but I just think it'd be nice for.
Yeah, of course. Forgive me. My name's Deborah Lee, and I'm the Chief Executive of Gloucestershire Hospitals Trust and of part of the integrated care system that we're here representing this morning. A regular face at HOSC, so you're quite right, Brian, to draw attention to that, but clearly not to the whole of the county. So thank you for calling me out on that. What I thought would be helpful, Chair, is if we could clarify, and I'm happy to give my view, it's in the paper, as to what is the role and responsibility of the committee this morning and what are the delegated powers to it, because I've heard a number of things said this morning which leads me to conclude we don't fully understand that, or certainly we're not in agreement about that. So would it be helpful if I just responded to 2 points there that have been raised and see if we have consensus about those points? Because I think without that clarity, we could debate things that are actually kind of theoretical almost. Would that be helpful?
Yeah, that'd be good, I think, yes.
So Martin, to your point in particular about the timing of consultation, this morning, my understanding, and we've tested this and it's in the paper that Joe and Ellen worked on, is that the purpose of the committee this morning is to confirm that the changes that are being proposed are considered to be substantial variations to service, and therefore are things that we should publicly consult upon. And it's the responsibility through statute for health overview and scrutiny committees to, if you like, make that call to confirm that these changes are indeed substantial and therefore warrant consultation. If we didn't move through that step, or we were to consult without coming through this step, or indeed to make change without consultation, we'd be acting unlawfully. So my understanding is, Chair, that that's the singular and only purpose of the committee today. As we said previously, we've lived this journey with you. I think we're all operating in the context that we all believe these are substantial changes, and therefore that we should consult, which is why we have prepared materials to launch that consultation today following conclusion of this meeting. Martin, I entirely recognise that the media has stolen our thunder in effectively launching it this morning with Mark's help, but we are where we are. So that's the purpose, Chair, of the committee this morning. In respect of your views about the validity of consultation, and particularly the timing of it, We are required, we would expect to take account of your views, of your recommendations, but we're not bound by them. And indeed, as a statutory body, can proceed to consult. Martin, you used language that suggested you perhaps had the powers to prevent us from commencing consultation. I, again, don't want this to seem at all adversarial, but that's not my understanding. We can proceed to consult if we so wish. What can happen at the end of this process, and this is what we've been very mindful of, is if you consider, for all the reasons you've said, that our consultation was in some way invalid and de facto unlawful, then you can express your concerns at the end of that consultation period in 3 months' time and potentially refer us to a whole raft of bodies and people. But it is at the end of the process. So I think what I'd just like to conclude on is that we have heard your concerns very, very loudly, very clearly. They've been very eloquently expressed, and none of them are without validity. We debated them some time, didn't we, together 10 days ago, and as a result of that, we responded in the paper that we presented, which I think addresses them. We are in a place, Chair, where I think we have a difference of opinion between the opinion expressed by a couple of your councillors and those of us that are representing the consulting bodies. So I just want to conclude by summarising the key 4 or 5 responses I have to the points that have been made. Firstly, we have tested these proposals against every scenario that we can conceive of. None of us know what the new normal looks like, but we can theorise about scenarios. And so we've tested these proposals against a number of scenarios, which is everything from the virus disappears through a wholly effective vaccine. We live with the virus at varying degrees, etc., etc. And we believe in all those scenarios that these proposals remain valid and serve us well. For me, most importantly, we have extracted a huge amount of learning from the first phase of COVID, and the temporary service changes are a reflection of some of that learning being further tested in practice. So whilst I recognise the point, Martin and Stephen, I don't believe that these proposals will change dramatically or even marginally as a result of more learning that is to follow. I think we've extracted 80% of the learning that there is to come around major service change through the first phase of the pandemic. Public engagement, we've talked about this before, we've talked at length. We have achieved better engagement through the new mediums of engagement, including all the virtual platforms, than we ever achieved previously. We've had more responses to our surveys, we've had more participants at our board meeting, we had what I would probably reflect as the most successful annual members meeting Gloucestershire Hospitals has ever run, in terms of the numbers of people that engaged in the live context and those that viewed the meeting and commented upon it afterwards. And then my final thing, and for me this is my most compelling point, it's the thing that drives me forward every day, is that if we don't go forward with this, we are delaying some of the most powerful benefits to patients in Gloucestershire that we've ever put before a HOSC. We've talked at length this morning about the benefits of improved outcomes, better experience, less to travel, care being delivered locally that would otherwise be delivered further apart. Staff who right now are choosing to go work in tertiary centres because we haven't got a clear strategic vision for the service that they want to work in. I could go on, and I won't, because I think we've set out the benefits case really eloquently. So in deferring in an open-ended context, we would all be collectively denying both our colleagues in hospital services and social care, but most importantly, 660,000 residents, we would be denying them access to these benefits. And hand on heart, I don't think the risks you've described are sufficient to outweigh those benefits. I think we can mitigate the risks. And if we've got this wrong, then you will refer us at the end of this process. So that, I hope, tells you how carefully we have considered the concerns that you've raised, because I wouldn't proceed with a consultation that I thought was starting out knowingly to be unlawful and likely to be referred.
Thank you, Deborah. I think I'll come back to you, Martin, but just want to say, as chairman of the committee, I have looked at the role of the committee and when and how we do things. And I'm very clear today that our role is to acknowledge that the changes are being proposed and to look at the consultation process. And it's when the consultation is complete, we do have a role where we could raise concerns that it hasn't been done in an adequate way, or that the outcomes are not adequate. So we do have a role there. I don't believe we have a role today that gives us powers to delay or stop the consultation. But I do think our role in terms of giving our feedback is important, and therefore the question raised about is this a good time to go ahead were very valid. So I think Stephen Martin bringing forward very valid questions which have been answered. So we now have to, as a committee, sort of say that we've raised those points. We don't, we're not in a position to say you can't go ahead, but we have raised those points, and obviously in due course we will be feeding back on whether we feel that that's the case. Personally, I think we have to recognise. We have to recognise that we only have been dealing with COVID for probably 7 or 8 months, and a lot of these changes were actually in the pipeline and things we were working to. This was actually going to come to consultation much earlier this year, and so it has actually been delayed by COVID to some extent. I think there is a risk of further delay, which stops us delivering the outcomes that the public need, and therefore I think it's probably right that the consultation should go ahead, because it's an opportunity for the public to feed back on that. The question is, can that consultation go ahead satisfactorily in this environment? And we are consulting not just on health, but on a whole range of other areas in planning and in our future road plans. So clearly Gloucestershire is consulting. So the question is, why wouldn't we consult on health? But that's where I am. I'm going to come back to Martin to see if he wanted to come back in. I haven't got anybody else seeking to come back in at the moment, so I'll go over to you, Martin.
Thanks, Chair. And I'm sure there are other colleagues who will want to say something, so I'll be very brief. But, I just want to reply. First of all, I don't think anybody has suggested that we're suggesting that what you're doing is unlawful. I haven't heard that from anybody, actually. But the more extraordinary suggestion is that we are in a settled situation, which is what Ellen said. Chris Whitty yesterday said that the cases of COVID-19 were now doubling every 7 days in this country. We are clearly heading into another very serious situation, and at a time when we have what I have to describe as a crisis at Gloucester A&E. I was told this morning that a news organisation now has footage of 16 ambulances queuing up at Gloucester A&E this week. So there is clearly a massive problem. I've had a clinician telling me that shifting the acute medical take to Gloucester will add to the logjam at Gloucester, and that you'll be underutilising services in Cheltenham and causing increasing pressures. So these are very serious things, and I don't think, this may be a temporary situation, but this is the entire point, that in this very strange and crisis situation, this is the wrong time to be planning these permanent changes. So we have to acknowledge, as you've quite rightly clarified, Brian, that the proposals in front of us are substantial enough to require consultation, but I think we should withhold our approval of it on the basis of timing, and we can only express that view. We can't stop it, but I'll formally suggest that. I'll post some words in the chat box.
Okay, thank you, Martin. I'm going to go to Dilys, then Bernie, and then to I'll come back to somebody else as well. So let's go to Dilys first. What's your question?
Great, thank you very much. First, I've got a question, and then I've got an opinion, if I'm allowed to express it. So my first question is, how do you envisage the staff being deployed across each site? I mean, particularly, I'm thinking about the surgeons in particular, where there's an emergency element and an elective element. Do you envisage that each individual doctor is going to be working seamlessly across both sites? And also, it occurs to me that the models for A&E in Cheltenham, where you're expecting consultant cover from 8 till 8, are very different from the model in GRH, where you're expecting consultant cover 24/7. So there's an element of how the shifts are going to work. So my question is really, would you expect that when you appoint new doctors, new consultants particularly, you'd expect them to work across both sites.
Chair, I'm happy to answer that question.
Okay, thank you.
My name's Mark Pietroni. I'm the Medical Director at Gloucestershire Hospitals Trust. I'm also an acute physician, which means I work a lot in A&E. So in terms of the question about surgeons, the way that the rotas work is that when the surgeons are rotated to be doing emergency work, they do no other work. And we have 2 consultant surgeons and a team on, and they work week on, week off. So when the consultant surgeon is doing emergencies, he or she isn't doing elective work, and therefore it's not an issue. It's the way we work the rotas. In terms of the question about A&E consultants, actually having different rotas in Cheltenham and Gloucester is not an issue. That's something that we've always had. They're slightly different environments and case mix. In fact, we don't have consultants 24/7 in Gloucester. Our rota has consultants in Gloucester to about midnight, 2 a.m. On occasion, consultants will stay late. They're really very good at that. And from time to time, if there are rota gaps, then our consultants will act down to cover the rota gaps. But that's pretty normal practice. So again, the rotating of consultants is not an issue. It's something that we do all the time. Final point about staff working on both sites. Yes, you're correct. When staff are appointed, not just doctors, but all staff now, they're appointed to the trust. They may have one site where is their main site, but staff are expected to work across both sites if required.
Thank you. Can I say my other bit now that was an opinion rather than a question?
Yeah, certainly do this.
Yeah, no, so I am a former clinician and I've worked mostly at Gloucester. I worked at Gloucester first in 1982 and I thought the 2 hospital model was very clunky then. And when I came back to work there for the last 18 years of my career, where I was a peer appraiser, so I appraised consultants and staff associate specialists from across both sites, and I could see that the model was still clunky, and it is always going to be clunky while we have a 2 hospital model. So, for example, your difficulty in deciding where to put the lower GI surgery emphasises how difficult it is if you've got different teams on different sites. So for me as a paediatric oncologist, it was quite difficult if I wanted an ophthalmology opinion on my child in Gloucester when the ophthalmologist at that moment was in Cheltenham. So there's always going to be that difficulty. And I know I'm just going to, I know this isn't up for consultation at the moment, but I was interested to see that a 1 hospital model has been deemed as the best idea for the forest. And although I realise it's very difficult for the two hospitals, Cheltenham and Gloucester, if somebody had grasped the nettle 40 years ago, when I was first working at Gloucester and built 1 hospital in the middle, we wouldn't be stuck in this difficult position today. So I'm just throwing a spanner in the works there, and I don't expect an answer to that, really.
Thank you, Dennis. I mean, I think the proposal on the table is actually 1 hospital spread over 2 sites. So I think they are moving to a 1 hospital solution. It's just recognising they've got
just not physically close together.
Yeah.
And there's an issue of transport in between.
Yes. Okay.
Sorry. Yeah. I just wanted to say that I think this discussion has been long overdue. The Fit for the Future consultation, and I'm personally pleased that it's going ahead even at this difficult time.
Thank you, Dennis. I'm going to go now to Bernie Fisher, who has also had his hand up, and I didn't notice it. So.
Yeah, I did have my hand up for a long time, but then I indicated visually.
Yeah.
But, as I am just a substitute on this, and I'm not as well versed as some of you, it strikes me as the outsider looking in, Joe Public almost, that we're looking to put things, more people travelling to Gloucester, Cheltenham, and things like that. When we're trying to discourage people from travelling, the travel time between Cheltenham, Forest of Dean, Gloucester, Forest of Dean is lengthening, not shortening. I have proof of that. My son lives in the Forest of Dean, It can take an hour or longer to get from Churchdown to the Forest of Dean. We don't know about transport capacities, and as both Martin and Steve have said, we're in the middle of a pandemic which has no end date. Who is to say that in March 2021 we'll be in the same position that we were in March 2020? All the indications are we're heading that way. It's certainly not going away. So we're making projections. We don't know the state of our health service will be in when we get to that point. I know people who are having doctors' consultations in car parks. Very nice in the summer, not too clever in the winter. I have had A&E experience where you are queuing for hours, to such an extent a friend of mine actually walked away on Friday evening last week at Gloucester, and then went back the following day because had to go to work the next day, and it was now getting near 1 o'clock in the morning. We don't know the state we're going to be in. I don't think it's the right time to consult because we don't know how our health service will be funded. We're throwing money, the government is spending money on COVID at the moment. In the end, we're going to have to pay the bill. And that will affect everything we do, roads, housing. We've also talked, I sit on both planning committees, both the borough and the county. We know that the population in the Forest of Dean is going to grow quite dramatically over the next 10 to 15 years. What capacity is being built into these new facilities or into the system generally? Because it doesn't say on the paper, as I've read, that we will be able to cope with that increase in population, which will only add to the transport problems of getting from the forest. And within the forest, transport is not good. You get a bit of snow on the ground and nobody's going anywhere in the forest. And people to get from Lydney, Blakeney and other areas to Colford may be physically impossible.
Thank you, Bernie. I think the points you're raising, I think we've noted, but they have to some extent been answered. So I'm going to go to somebody else to get their comments first, and then we'll take feedback on all the points. So I've got Stephen Hurst next. Are you there, Stephen?
I've got two subjects. One is regarding the repatriation of services that we currently send patients out of county to other places. Now, it may be that these other places are really regarded as super centres of excellence, where places like Bristol, Oxford and Birmingham really do have high quality facilities to deal with very serious cases in their speciality. What I'm asking is, will we have an expectation of more capital investment and skill in higher skill levels through extra training and familiarization, so we bring our staff up to the level of super centers of excellence? And that still also goes to the capital expenditure, where these super centers have huge modern facilities of x-rays, scans, whatever. Will we be able to reach those high levels of modern equipment in our centers of excellence? My next area is regarding the actual principle of consultation. There's no doubt the proposed changes are very substantial and material, and therefore it may well be foolish not to allow the consultation to go ahead. But the pace of consultation may have to be flexible to ensure that maximum public engagement is achieved. We can't afford to delay anything which gives us much improved health services in Gloucestershire. Thank you.
Thank you, Stephen. I think maybe is that to go to Simon or to Deborah? Because part of your question was about, I suppose, ambition and what we're going to be able to bring to Gloucestershire through these changes, which was in the report, but maybe you want to come back to. And the other one was whether the consultation needs to actually be a bit longer.
Yeah, I'll kick off, and Deborah and Mark might want to join. But thanks, Stephen. I think this is one of the reasons that we want to continue and go ahead with the consultation, because you're right. Some of this will involve capital investment and development, and it will involve recruitment and training of our staff. But without having the strategy agreed, it's very difficult to do that. So there are pots of money that we can access nationally. And the first question NHS England will ask when we try to do that is, what's the strategy you're trying to achieve, Gloucestershire? And without having that clarity, it puts us further down the running order to get access to that capital. And similarly around workforce as well, we mentioned it, when people come to look at hospitals to join, one of the first things they do is go online and look at our strategy and understand how the hospital is developing and where's the level of ambition. And we've seen some of that already. People are attracted because we're starting to talk about this centres of excellence language, but you can only talk about it for so long. It has to turn into action. So that's one of the reasons that we want to continue to go to consultations, to get clarity on that strategy, because then we can make applications for further capital and we can be clear in our recruitment about where we're going.
And Simon, I'll build on that. We've got a really great contemporary example, Stephen, and it's a great question. It goes right to the heart of the current situation, is that we have the irony at the moment of two of the most outstanding interventional radiologists employed by Gloucestershire hospitals who go to Birmingham to ensure that their skills are not lost and maintained. So they take patients from Gloucestershire to Birmingham for their care when those patients reside next to us and those staff are employed by us. So just to echo Simon's point, not only is it vital that we develop the strategy so we can develop the plan, but my concern is that we won't retain that kind of talent for very long if they can't see a really clear future for them. So I could give lots of examples of that. We've got cardiologists who work in the Bristol Heart Institute. So we're starting with some really skilled individuals, but as you say, we need to skill the whole workforce. But without the plan, it's a pipe dream.
Thank you. Thank you very much.
Thank you, Deborah and Simon. Now I'm going to go to the last person I got on my list.
Excuse me,
Nigel.
Oh,
Nigel Robbins.
Can I just ask a question?
Well, I've been waiting. Pam, to
sorry.
ask a question.
Nigel has been waiting a long time.
You don't mind? Yeah, can you hear me all right? I hope so.
Yes, we can.
Yeah, I've got the question really is about the performance indicators for this public consultation. Do you have very clear performance indicators in terms of media, quality and numbers? Because to pick up Councillor Lydon's early remark, about the insecurity of some of the outpatient services, those things are going to preoccupy a lot of local residents when they come to respond to your consultation opportunities. I mean, for example, in Cirencester, as everybody knows from the eloquent presentation by Marco Taylor at the last meeting, which I couldn't attend because I was abroad, the phlebotomy services, the blood testing service at Cirencester Hospital has been extremely limited and truncated, and even the undertakings to resume and to expand the service that were made recently have not been sustained. Waiting times are very poor, and we don't know what's going to happen in December. So those kinds of deficiencies, although, and I'm sorry to hear Ellen say that those things are still, like the poor, going to be with us after coronavirus, those things are going to be preoccupying. I'm more than happy to acknowledge, as Brian has suggested, that these changes are significant. I would suggest that another 6 months of bedding in of those temporary changes would produce a more positive and widespread and properly understanding response than you'll get in the next few weeks.
Thank you, Nigel. Right.
Should I come in?
Back on that. Is that Ellen or? Yeah, Ellen.
Pam wants to speak, Brian.
Oh, yeah, Pam, do you want to come and raise your question?
Sorry, Brian. I was trying to respond to Nigel's points, but I'd accidentally not unmuted. Shall I just respond to Nigel's question?
Yes, okay.
We'll take performance
indicators. Come back to you, Pam.
Yeah. I think specifically, I think some of the points were more general and we've probably covered them in other responses, but I wanted to specifically respond about the performance indicators. So one of the things about consultation, and we've talked to you in other consultations, is there isn't a kind of hard and fast numbers game. We can't say, you know, when we get to 27 out of 63, then that's good consultation, and if we've got less, it isn't. So there isn't a kind of straight line where we can say that's sufficient, that isn't, but it's much more nuanced than that. But what we've built in is, with our expert advisors, the Consultation Institute, we've built in a sort of half-time review, which we'll be very happy to share with you, where we're going to do a stock take, see how that's going, look at the feedback we've received so far, look at the response rates, think about the activity we've got going on around the consultation and the feedback, and do an assessment with them, and then have a think about if there are any mitigations we should put in place, such as other opportunities for people to talk to us, or extending time is another opportunity, although that does obviously take resources if we do that. So we're going to do that midterm review. We'll obviously share that and we can have a conversation about it at that point in time. We have, as well as all the virtual means that we said, we have a mail drop plan to every household coming up at some point in the consultation, just trying to work through the details of that. And also the information bus, we fully risk assessed it, and with PPE and cleaning and so on, we can still use that facility, and so that will also be out and about in local communities. So we've got the normal means, normal in inverted commas, means that we would use to do consultation, with actually a whole added layer of additional mitigations that we're putting in place, or, for a better word, opportunities. And then we've also got the second citizens jury planned. And one of the things that they will also look at is the consultation. So I think, you know, we are building ourselves multiple opportunities to review and to be assured that we've been able to get a good response to the questions we're asking. But I would stress that won't be about when we reach a certain number, we'll consider it good. The sort of academic literature on this in this field talks much more about the quality and the detail of the responses you get. So a small number of really good responses might be better than a very big number of very cursory responses. So it's not about we get to a figure, we deem it done. It will also be the quality of what we've got and all the opportunities that we've provided. And that's what our trusted expert advisors will look at with us.
Yes, I can't disagree with your last comment about the quality of the responses, but we look forward to the half-time review. Thank you.
Yeah.
Thank you, Nigel. Right, let's go back to Pam. Did you have
Yeah, well, actually, thank you, Chair. I think just has answered my question, which I followed up from Nigel, which I penned in earlier on. I'm a more practical person, and I'd like to know what if people haven't got access to line? How, you know, and they're the more mature people who would like to contribute something, but I think you've asked this. I want you to enlighten me now on the mail drop, and it's just reaching out to those other, I would say, 50% of people who can't access online, and you know, where do we go with that? Because how do you get a true calculation of what is good and what's, you know, not bad towards the hospital? So you're knocking a few people out really here. Thank you.
Pam.
Now,
did you want to come back on that, Ellen, or?
Well, I think, I mean, Becky might want to comment, but as we said, it's not just online. So we will be out there talking to people safely where we can. And we have got methods via the mail drop and so on that don't require people to have access to a computer, because completely agree with Pam, not everybody does and not everybody's confident. And we'll offer opportunities for people to talk to us on the telephone if they want to do that as well. So if somebody wants to have a telephone call, they can do that as well. And there's a way to respond that doesn't involve you having to go near a computer if you don't want to do so. I don't know. Have I missed anything, Becky, or did you?
Well,
Does that cover it?
a minute, Helen? I'm overriding. I'm very rude, but telephones. Are we going to wait quarter of an hour to get through someone, or are you going to have special people or volunteers who could sit and man those phones? Because it takes ages to get through. Thank you.
So, I mean, I would love it if we had that many people that want to talk to us, but we expect what's more likely is we'll make a telephone appointment and we'll have a book time to have a conversation with somebody. So rather than a kind of hotline effort, but I think it's more likely we'll make appointments to have a scheduled slot with somebody and they can book a call with us, because I agree, we wouldn't want people sitting on the phone wanting to give us their feedback.
Hi, Pam. Just to say, we're going
to ask to do that with a tick list. Thank you.
Hi, just to say, Pam, we're asking people to leave a message for us, and then we'll call back, so they won't have to wait to leave that message. Okay.
Okay. Thank you. I don't think anybody else is looking to speak. If they are, do shout out now. I think I'm just going to sum up where I think we
Brian, sorry to interrupt. There's a question in the chat which I might need to answer. I think it's.
Yes, if you want to answer that, Ellen, I was going to come to that, but you can answer.
Oh, sorry. I didn't mean. I thought we were moving on to the next item.
If you want to answer that question about the citizen jury being binding.
Yes. So at the end of the day, our statutory functions mean that the board of our organisations need to make a final decision. So citizens jury can only be advisory because that's set out in legislature about the different responsibilities, and the citizens jury doesn't have formal status. That said, our precedent so far on the forest is that the board and the governing bodies of the two organisations fully accepted the recommendation of the citizens jury. So that is the process that we follow. So citizens jury make a recommendation to the board. The board listens to that, but the final decision always sits with the organisation that has the statutory powers when we're talking about a business case like this that requires investment of public money and so on.
Thank you, Ellen. Yes, I just wanted really to pick up where I think we've arrived at. Clearly, I think the committee does accept that the changes are substantial enough to warrant consultation. So in that sense, the test is met. There are some committee members here that feel that it would be a good idea to get on with this consultation straight away, and clearly others who feel that it runs some risks. And at the end of the day, we do have risks. Living with COVID gives us risks, and I suppose there always are risks. So the balance, clearly a number of those risks you've looked into, you've explained how you're going to mitigate them. And as a committee, there is still some apprehension from some members on the timing. But other than that, I think the consultation we accept is something that has to happen. And obviously, we will be looking at the end of the process to see whether the consultation has been effective. So I think the feedback that we've given and the points we've made will help you to deliver that. So, thank you, everybody, for your contributions on this. As I said, we're not in a position of saying you start or go. The consultation will go ahead, and hopefully it will be a successful consultation, and we can all be looking at the feedback in due course later this year, or probably early next year by the time we get it assessed. So thank you very much. I'm going to have a quick 5-minute recess, I think, whilst before we then come back to the next item on the Forest of Dean. So if we want to just go on, do bear in mind that whilst we're on the recess, anything that's been said with the microphone on will be heard by anybody watching. So just either switch the microphone off or be careful what you say. And we'll get back together at, say, it's 11:43, so 11:48. Okay, 5 minutes. Thank you.
Just to remind everybody that YouTube will still continue, so if you want to turn your videos off, that might be useful, as well as microphones.
Joe? Joe, are you still there?
I am.
Can I ask you something?
You can. But you remember that we're on YouTube and that the public can hear.
No, it's all right. It's just that when we've had the GP briefing, and I'm just wondering, is today the time? I don't know if we've got time to actually ask any questions on it, or do you want me to send them in separately?
I think does it relate to the next item?
No, it doesn't relate to the forest, but it does relate to COVID stuff, you see.
I would send them in.
If I send them to you, yeah?
Send them separately, because we're going to look at the work plan at the end of this meeting. We have got our next meeting on the 17th of November. So if there's in particular that you want to raise there, suggest it under the work plan.
Okay, yeah. I mean, I won't labour. I will email you. The big concern is that GPs and primary care are outside of all the stuff we're doing on COVID. That's the gutsy question. And the other one is about I've had a few people contact me. There were issues with blood tests, and I know they've got the phlebotomist problem in Siren. Shall I email you again separately about that so you can put that into the mix with the CCG people?
Yeah, I'm conscious at the moment that we're not in the meeting, so I think best to just email anything over. But if you want to raise anything under the work plan at the end of the meeting that you would like to suggest is considered at a future meeting. Okay.
Yeah, okay. I prefer a quicker answer, to be frank, but you can see where I'm coming from.
Yeah, no problem.
All right. See you in a minute. Cheers.
Okay, I think some of us are back. Can't see everybody's picture here, but we're back at that time. So what we're going to be doing now is looking at the Forest of Dean Community Hospital item. Let's see who is Ellen back? That's probably the main question.
I've just arrived.
Okay.
Brian, can we just give it another minute just to make sure all the members are back?
Okay, we'll give another minute to go.
Could I just check that I can now be heard?
Yes, we can hear you now, Ingrid.
Excellent. I've managed to get my laptop to play ball. Thank you.
That's right. We no longer have you down as number 9 then.
Ingrid.
No. Pardon?
If you want to turn your video off, we can hear you better if that's an option. It sometimes helps. We're ready, Brian.
Yeah, I think we've got most people here. I can see Pam's just coming back. Right, let's move on then to the second item on our agenda today, which is the Forest of Dean Community Hospital. So I think we're back to Ellen to present on this one.
Yes, that's right. Thank you, Chair. I will do the same thing. So I'll take you through the covering paper, and then I think my colleague Angela is available if there's any more questions in detail from the provider point of view on the model that we're proposing. So the paper you've received sets out an overview of our proposals for the Forest of Dean Community Hospital. Now, members, again, in terms of being a long-running programme, we've actually been doing this one since 2015, so even longer than Fit for the Future. And we hope this is now the final stage of moving towards actually getting this new hospital built for the locality. So our last period of engagement on the Forest Hospital highlighted some key issues that were of particular interest to the local population. And so this is what we're now coming back to address through the last phase of, well, I hope the last phase of consultation. I should call it the next phase, I guess. So just to be really clear, we are not asking the question again about should we have a new hospital, because that question's been answered. We're not asking the question again about where should it be, because that has been already decided by the recommendation of the citizens' jury and accepted by our boards. Indeed, we've actually gone as far as purchasing a site and agreeing that with the local council. So, what is this final phase concerned with? It is concerned with the proposed inpatient capacity in the new hospital, urgent care provision for the district, and also in particular, this was raised to us around the south of the forest that we've heard from John this morning, end-of-life care provision and travel and access. So these are the things that people mostly talked to us about in that last phase of engagement. In terms of the assurance and oversight that we go through, as we do with all programmes and we've outlined on Fit for the Future, we have met the tests, but a particular important difference with regards to the Forest of Dean Community Hospital is that we did need to address the bed test with regards to our proposals. So for those who are aware already of the configuration of services across Lydney and the Dilk, I'll just reiterate that at the moment, those sites have available to them 47 beds, although since March have had open around 30. And our proposal for this hospital is that it will have 24 beds. Therefore, we needed to provide evidence regarding the bed test, the NHS England bed test. So the bed test has a number of specific requirements, which are firstly demonstrate that sufficient alternative provision such as increased GP or community services is put in place ahead of closures and the workforce is there. That specific new treatments or therapies will reduce specific categories of admission, or where a hospital has been bed, say, less efficiently, that we plan to improve efficiency, which will therefore reduce the requirement for beds. So we felt we had evidence against all three elements of the bed test, which is what we have gone through in a lot of detail with NHS England. So firstly, demonstrating sufficient alternative provision. We work extensively on this element of the bed test. So firstly, two really key services have been introduced to the locality over the last 5 years and are now up and running. So the first is the complex care at home service, and the second is the rapid response service. Both are community-based nursing care services that provide care to people in their own bed as opposed to in a hospital bed. And both of these services now care for more Forest of Dean residents than in our hospital bed base. And we have all the data on that available, and that will all be, and in fact some of it is already in the public domain on our Forest of Dean website. As the name suggests, complex care is providing care for people with really complex needs at home. And you've got a little case study of that in the Forest of Dean consultation booklet that we've provided to you. Rapid response, again, as the name suggests, is for people who need care at home in a crisis and can provide a very safe alternative to hospital admission with all the detriments that that can bring. We have some other alternative provision in place coming into our locality as well, affecting the needs in our locality, which is firstly, the national strategy around end-of-life care sets out that wherever possible, support should be provided for people to die either at home or in a sort of homely environment. So not ideally in a hospital bed with all the other issues that that presents. So in line with that, our county-wide strategy is to provide hospice care. And for the Forest of Dean, what that means specifically, and I know we've shared some of this with you before, but is working with the Great Oaks Hospice in the Forest of Dean, who don't have their own bed base, but they provide outreach care for people at home. And they also, we have added to their portfolio of the offer, effectively, the opportunity for them to spot purchase a bed in partnership with the patient at a care home of choice to provide their outreach arrangements there, should the home not be suitable. We've also introduced a stroke rehabilitation centre, effectively a community-based centre at the Vale Hospital. And this affects, our calculations show, about 1 to 2 beds of historic use of community hospitals in the forest, where for those patients who've had a complex stroke, they will be better served clinically by having specialist rehabilitation at the Vale. And then the final aspect is that we know that historically, the beds in the Forest of Dean hospitals are approximately 50% utilised by people who don't live in the Forest of Dean. So who are put there primarily actually from Gloucester City area, a few from Cheltenham and Tewkesbury and so on, but primarily from Gloucester City. And we have now purchased additional rehabilitation beds in Gloucester as part of a county-wide offer called the Enhanced Independence Offer, again focused on getting people home, providing them with rehabilitation and maximising independence. The next point is around, the second part of the BES test is around specific new treatments, that point. We felt it wasn't specifically that applicable to this case, although I think there's a sort of slight read across around the rehabilitation provision and the new end-of-life care model. But principally, we felt that that didn't specifically apply in this instance. And then the third point is where a hospital has been using beds less efficiently than the national average, that we have a credible plan to improve performance. So one thing we've been trialling since March, when the bed stock in the forest hospitals was moved from 47 to 30, as I described, in response to COVID-19 and the lack of ability to put infection prevention control measures around the estate in the forest hospitals. We've introduced 7-day rehabilitation to support flow in those community settings in the Forest of Dean. What that is showing us is that new model of care for rehab does improve length of stay in the community hospitals and improve efficiency. We haven't actually factored that into the model because we haven't been doing it very long, and we also wanted to have a sort of buffer regarding the number of beds proposed. But we believe that greater efficiency is possible and that we have evidence that that is the case. The one thing we have factored in is that our planning proposals have assumed we will no longer have what are called, in the kind of NHS language, super stranded patients. These are patients who effectively are stable for discharge or could go to some other care setting, but have remained sort of stuck. You sometimes hear them referred to as delayed discharges with a length of stay over 50 days. Because in our system, we collectively don't believe that this represents a good quality experience or care outcome for our patients. And although that's a relatively small group, it doesn't take very many people that sort of data in your whole data assessment to really skew the numbers. And we found that in terms of the utilisation over the last couple of years, a couple of patients, a very small handful, had contributed a large number of stays, including one that was nearly a year. And clearly, there must be a more appropriate setting for that individual than being in a hospital or somewhere that feels more like home. So in terms of the statement of assurance for the Forest of Dean, in testament to how long we've been doing this project now, actually, we'd already met test 1, test 2 and 3 and 4 in 2017. With our assurance partners, NHSEI, we did re-review test 1, given that further engagement has gone on, and we are now proposing a phase of consultation. So that has been assured in 2020. The NHS beds test hadn't been reviewed in 2017 and was then, because we hadn't finalised our proposals at that point in time, but has been fully assured in 2020, as has a further financial review and implementation plan, because clearly costs have moved on in the intervening 3 years. So the key points I would say is that the updated proposals in the document have been developed in common with Fit for the Future, with a very long running now programme of feedback and engagement with local communities. As John referenced, we speak a lot with the local community groups, and we have our locality reference group that has continued. We've only had one meeting over the summer virtually, but that worked well, and we have that format established now. And the consultation will provide more information, therefore, on inpatient bed numbers and community alternatives, the urgent care service in the new hospital, those end-of-life proposals I talked about, and travel and access, and all the insurance has been met. So given I've shared quite a bit of detail on the inpatient bed numbers, I'm not going to say a huge amount more than I've said already. But we do confirm that we plan to provide 24 beds, and for the reasons I've explained. There is some detail in the paper further down that shows you those percentage residency occupants of the beds. So around about the low 50% occupying the forest beds from the forest locality. I've talked about our challenges that we had through COVID regarding infection prevention and control, and our thoughts at the moment is that we will aim to build this new hospital with 24 single self-contained rooms with ensuite bathrooms, although we do still have to finalise the costing on that, because of course that is a more expensive build to do than bedded bays. We've talked about the 7-day therapy model, which we plan to introduce, and there has been a significant benefit for patients from having 7-day therapy support. And they can get home more quickly and face less risk of decompensating due to excessive time spent in a hospital bed. I've also talked about the development of community-based services and how those are starting to pick up patients now, and that more care in our locality is actually provided in people's own beds at home, supported by community services now than in hospitals at all. Moving on to urgent care, we do plan to provide a minor injuries and illness service unit in the new hospital, as we have always said that we would. But there are things that continue to change and evolve around our urgent care model. So the first to say is that minor injury services increasingly are becoming pre-booked. So that is the case now, that is happening now. That's not new specifically to this, and is a national movement towards using NHS 111. So talk before you walk is the sort of strapline there. enabling you to book a time and to avoid long periods of time waiting in waiting rooms to be seen. The second point is that although we've always had them as minor injuries and illness services, actually the vast majority of urgent care is provided in primary care, who are the first port of call for illness services, and indeed some injuries that don't require an X-ray. We've also extended opening hours of primary care, and in the Forest locality this is the same as across the district, and there is extended access, and as I say, the vast majority of urgent care, even with the recent troubles in access with COVID, remain in primary care. But we have modelled the unit on its ability to take varying levels of illness, and effectively there's a kind of fixed cost in a minor injuries unit of that size that provides us with security over the amount of use, but also flexibility should things continue to evolve, as they always do in service provision. We've particularly acknowledged the concerns regarding the south of the Forest and an urgent care offer, and that's one of the things we're going to look at in the working group. I've talked about end-of-life care provision, and the proposal there is around a partnership approach with Great Oaks Hospice, and providing care either at home or in bedded spot purchase beds. In terms of travel and access, this is always something that we hear about with regards to the Forest of Dean and the significant challenges in travelling around the district and out of the district. And I think this was mentioned by Bernard when he raised his points earlier. I slightly smiled to myself when you said it feels like things are getting further apart in the Forest. It does feel like that. I live here myself, and it can take an absolute age to get anywhere, particularly if you want to get to Gloucester or whatever. So we do recognise this is a real challenge for people. That said, we've got a reasonably limited ability to directly impact on transport as the NHS. But one of our colleagues has joined the locality transport group linked to the district council, and is pressing for bus routes to go to the new hospital site. That does tend to happen when we work with our partners in travel and transport, so we're very hopeful that that will occur. And we also looked at car ownership in the district, which actually, I guess unsurprisingly, given the state of the parlour state of public transport, car ownership is high in the district. And over 80% of people who responded said they had their own motorised transport, and only about 10% relied on public transport as their main mode of transport. There is, of course, other options in terms of community transport and so on, and voluntary organisations who provide an absolutely invaluable service in this regard. But I think it is something we need to continue to play a part in to try and campaign to have good transport access to our new site. Our analysis showed us that Sedbury would be the area in the Forest of Dean facing the longest drive to Cinderford. But our analysis of actual use, and we've looked at use from people from that postcode, they do also access services in North Bristol, which is actually a shorter drive and no longer subject to the 7 bridge tolls. And there is also a new community hospital planned by the Aneurin Bevan Health Board in South Wales, which may enhance choices for local people in terms of access. So I'm not saying that answers all our issues, but it's just interesting to flag that up as well. And as I said, we do take that concern very seriously, and we'll continue to work with this working group around services in the south of the Forest. There's a little bit more on the travel and transport analysis there for your information. Finally, in terms of ambulatory care, and by this I mean services such as endoscopy and outpatients, we plan to offer both of these in the new hospital. Endoscopy, providing we can pull this off, would be a new offer for the Forest. And so it would be a locally available service, reduce the pressure on services within the main hospital units, and it's something we're actively planning to deliver in the Forest Hospital. It's also something that increasingly is increasing in terms of use, particularly in the older population, which are quite, the demographics of the Forest are sort of weighted towards the older population. So we feel this will offer an enhancement to the current service offer in the community hospitals. So our proposed timeline is effectively the same as Fit for the Future, but without the final period, because this wouldn't be subject to the citizens' jury approach that we've put in place for the Fit for the Future programme. So you have the timeline in section 4, and our proposal is that we would run until sort of mid-December, review in January, and be able to complete our full business case and progress to start to build this new hospital quite early in March 2021. So following on, you've got the public consultation document that sets this out, and I think there's a short presentation as well, which, Angela, I don't know if there's anything you want to add or if we want to open for questions from that point.
Thanks, Ellen. No, I think you've covered everything that would have been in the presentation very fully. Thank you. So I'm happy to open to questions.
Thank you. That's a very clear presentation. There's somebody that I think was working with Caroline 5 years ago doing the first stage of consultation. It does seem an awful long time that we've been involved in this. And actually, one of my comments from that was most of the feedback when people engaged was about their primary care and their local surgery. And I think that's one of the challenges sometimes that when people get the opportunity to tell you what they think about health service, they're not necessarily always focused on the part of it that you want to deliver. They just want to use the opportunity to tell you what the issues are that they have. Now, I can't see any hands up at the moment, but I'm sure people do want to. So can I suggest people actually wave at me and I will then pick up their points? I can't see anybody. No, can't see anybody waving out. So am I taking it we don't have any questions on this consultation? Nigel, oh no. It's looking very much like that. So obviously the points raised in the previous discussion about how you successfully consult still apply here. And I think there's an additional one, of course, is that if you're going out to consult, I see your point, Bertie, so I'll come to you. So if you're going out to consult on 2 topics at the same time in the Forest of Dean, how are you going to be sure that you're getting, or are you going to be able to consult and engage people on the 2 different areas? But let me go to Bernie, and he can give his question.
Yes, it's interesting that Ellen refers to the older demographic in the Forest, but with the new building and new house building that's going on a lot in the Forest, that is changing. I don't know how old our demographic information is, but also with the Forest of Dean now is commuter belt for Bristol, South Wales, because of the bridges being free, and also, again, COVID related, people now are looking to move from urban to rural, and working from home is being encouraged a lot more. So with one provision in the Forest, if you can get internet connection, and we all laugh about it, but it really is really serious in the Forest of Dean. I know people who live at Sudeley who have no chance of a mobile phone. Mobile phone is just a paperweight because it's useless. You cannot get, whichever provider you have, you can't get any service. And the same with internet. It's so poor. We've got to get better connection into the Forest. But you say about transport, the NHS does impact on transport. I know you have little influence, but with ambulance times, and as you say, getting to Gloucester Royal, getting to Cheltenham and places like that is taking a tremendous length of time because people are commuting out of the Forest. There's 700 kids a day travel to schools outside the Forest. That's a school the size of Pittville in Cheltenham every day gets on a bus in the Forest of Dean to get educated. There's lots of things that we've got to look at in the infrastructure of the forest to make sure our hospital that we provide there is giving us the service we want, because the forest is changing quite dramatically.
I couldn't agree more. I think particularly about the broadband thing, I'm sitting as close to as I can to my router and the mobile phones. It's a real challenge, and also I think for the demographic. So I think it does tend. Well, this is compared to all Gloucestershire, and I guess what we're looking at is around that's a good case to provide endoscopy, but that's not just the basis for all our planning. So I think the other points around some of the younger age groups are around some of the, again, it's not all black and white because of course you can't completely stereotype, but around some of the ambulatory care offers. And we do need to work this piece through around the offer around the south of the forest where a lot of the building is going on, as John raised at the start of the meeting. So it is also important to remember as well that Forest is quite a small district, certainly smaller, not in geography, but in population size than a number of the other districts around the county, albeit is growing. And we have modelled on the current demographics, the projections from the Office of National Statistics, but also looked at some of those big house builds, because we've also got the ones all around the Sudbury area and Tuts Hill. I mean, I agree with your point as well about the commuter issue, although none of us are ever going to be able to get out once we've got 30,000 more, or 5,000 or whatever it is, more people trying to go that way and 5,000 people trying to go the other way as well. But anyway, that aside, we do, I do agree we play our part when it comes to transport, but these are all things we need to think through as I think the kind of future nature of how we live and work around the area is changing. But for me, that's much more, the community hospital is one part of our network of whole county provision. Whole district provision. I'm bundling up county and district because we've had two topics today, but district provision. And that's also our strategy around the developing health centres. You'll have seen Valley Road has opened already in Cinderford and Colford is underway.
Thank you. Thank you for that, Bernie. I think it's worth, as we're in a public meeting, picking up what an area that's close to home for a lot of foresters is the maternity unit. There has been a long-standing call for that to be something that's available. Is it worth just getting your feedback on why you don't feel that's an important part of the hospital?
Yeah, happy to do that as well. We had it raised in the first part of the consultation, and we did a piece of work to look at it specifically. So there's a couple of things. So obviously, again, like we've talked about with Fit for the Future, medicine's changed a lot from the days quite a long time ago now when the Forest had a maternity hospital. Two things have changed. So one is we provide a lot more support now around home birth. So people do have babies in the Forest. They have them in a home setting, supported by a team who come out and provide care for a home birth. We then have people who, for reasons of maternal risk, so on and so forth, would not be suitable for that, and they need to be cared for, to use the sort of language we've used earlier, in something more akin to a centre of excellence. So technology's moved on, safety requirements have moved on. Maternity is extremely litigious and sensitive area of NHS care, and certain requirements exist, such as the availability of theatres, the availability of obstetricians, the availability of anaesthetists to give epidurals, and so on and so forth. And it's a more specialised business. We could debate that, in terms of more philosophical stance, but that is the way it is. So I guess the Forest Hospital falls somewhere betwixt in between, which is we certainly couldn't provide an obstetric unit with a theatre and an anaesthetist and all of those things at that scale. So that's a no. So the only alternative is something like a home birth, because that's the low risk alternative, which is midwife led and doesn't have those other things. So one thing we looked at is what's called a pop-up unit, but that is effectively a room with a set of keys which you can go and use if someone doesn't want to have a home birth in their own house, but they want to have effectively a home birth in an NHS setting. There's quite a lot of challenges with that, not least the cost of keeping that room available, keeping it stocked and so on. And the other thing is it being quite a small locality, the rate of births, and then layer on top of that the rate of births that are eligible in that very low risk category, who could use that, is really small. To make that sustainable, because basically you have to have staff who'd be available to man it. You've got to keep all the equipment washed and clean. You've got to have it basically ready to use at any given moment. And we didn't feel that that was doable or deliverable or particularly could be robust. So that's where we got to on that. We did look at it really carefully. We even costed it. It's also really expensive per birth. And what we feel is that by offering, as we do already, the home birth, then people can have their baby in the Forest of Dean. It is important for some families to be able to do that because, as you may be aware, if a baby is born within 100 of St Breville's, they have access to various ancient rites. So we can support that for a mother who can have a low risk delivery, but we could never support that for those who need a high risk delivery in the Forest. And so really there, it wouldn't offer any alternative to what we already provide through our home birth service. So I hope that reassures you, we didn't just dismiss that matter out of hand. We did a quite considered piece of work on it. We talked to our midwifery teams, we put together a proposal, we costed it, and concluded at the end of that that was not deliverable for the reasons I've outlined.
Thank you, Ellen. Yeah, very clear and well explained. I don't see anybody else wanting to speak. So, Terry, you want to come in, do you? You need to put your microphone on, Terry. That's it.
Ellen, I'm just wondering, you know, we're talking about a lot of home services that's going out to the homes and so on. Have we got that infrastructure in place to actually do that? Because that worries me. We also, you know, you said the rapid response. Is that a section of rapid response only for that certain element of surrounding the forest, or is that a rapid response that comes in from from SWAS? There's a few things that you know, I think people are worried about with the 24 beds. You know, is those, you know, we're going to take every obviously 24 our forest people, we hope. Is that your plan?
I can't hear you, Ellen.
I should have done so well at remembering to put it back on, and then just at the last minute. So really good points, Terry. They are teams that are based in the Forest of Dean. I don't know, Angela might want to comment, but they are already there, and they already work in the forest locality, and they aren't county-wide teams. They are locality-based teams because they work really closely with primary care as well in the area. So, Angela, if you want to add anything to that. She's finding her microphone, I think.
So I'm used to being at the top. Yes, I think quite right, Ellen. These teams are established at the moment. I think if I was to look at the Tewkesbury and the Forest of Dean, I was just trying to find the precise number, but there's over 50 staff employed in that integrated community team at the moment in the Forest and Tewkesbury locality, because we deal with that as one locality. So they're already providing those services into people's homes at the moment. And will continue to do so. So it's a fairly stable resource that we have. And obviously, in terms of future direction of travel and future investments, it is an area where it's in the national policy to continue with a home first model, and where we will continue to focus on ensuring that people can receive care as close to home or in their own homes, wherever it's safe and appropriate to do so. And those teams, I should say, there are separate teams in each locality. So Gloucester and Cheltenham have their own teams on top of what the Forest provide in terms of their team. So we very much look at this service on a locality basis.
And where will those teams be based, or where will the Forest teams be based?
So the Forest team at the moment are based in Dean House. They will continue to use that as their base, but obviously they work out and about into the health centres in all of the district localities and link up with primary care. But their actual physical base is intended to remain as Dean House at the moment.
We're looking at the doctors isolating a lot, like doctor surgeries isolating a lot of patients in the Forest Dean. My surgery, we for a repeat prescription, we've got to ring 0300, and we could be hanging around for 15 minutes to get a repeat prescription. I don't want that happening with the Forest. With a Forest setup, I want that ironed out if we possibly can, because we got an elderly population, and some of them haven't got computers. They haven't got mobile signals is low. Can you reassure me that that is being looked at? Because I said, most doctors now, doctor surgeries, and I've had a lot of people ring me up and panicked over the pandemic that's happening, and they feel isolated because you gotta you have to get an appointment, and you gotta do it online, and so on and so on. People, they are actually terribly upset that they can't get hold of a doctor.
Thank you, Terry. Is that something perhaps that Andy Seymour might want to comment on, because it's not really the consultation, it's actually about primary care in the Forest during COVID.
Yes, thank you, Chair. Yes, I do recognise the issues that some patients will have accessing practices, but as I've reported before, sorry, I should have introduced myself, Chair of CCG and also a GP. All practices are open to patients, and all practices are seeing patients face to face. But to do with COVID, they do have to have quite clear access criteria because of minimising the risk of bringing potential COVID into practices. So this is why most practices will operate what's called a triage first policy, where they'll try and speak to patients or accept an online consultation first, just to assess whether a clinical face-to-face appointment is required, or whether the issue can be managed either online or through the telephone, or indeed via a video consultation. And I do recognise, certainly as we've been hearing, that certain parts of the Forest that internet capability isn't as good, and so I do know also that the practices will have to adapt accordingly for these populations. But as I said on previous meetings as well, if there are specific issues, I'm more than happy to take them in terms of particular practices being involved. I'm happy to take this outside the meeting in due course.
Thank you.
Thank you. Okay, I think just to come back, I don't think anybody else is indicating to speak on the main topic we're talking about. So I would just sum up on that to say I think that we welcome the consultation going ahead. We note the time it's taken to reach this point, and we'll be interested in looking at the outcomes. And I suppose our qualifying point really reflects what we said on the previous item, as we do want you to make sure that the consultation is one that's genuine and that people are reached, despite the difficulties that COVID presents for doing consultations at the moment. So thank you very much. That, I think, brings our key agenda items to a close, but we have on our agenda the future meetings noted, and we're also going to look briefly at the work plan. So to start that, I'm going to go first to Joe Joe, can you just highlight what we've got on our work plan at the moment, and then I'll take any comments from councillors that want to amend it.
No, at the moment for November, the meeting is on November the 17th, and we've got the blood testing, the phlebotomy item that will be coming. A report will be coming to the meeting. We haven't got anything absolutely firm at the moment, and happy to ask Becky Parish to come in if there's anything she wanted to suggest. Items that have been sort of on the work plan for a while was from SWAS performance indicators that should have come to the March meeting, but because of issues over the past 6 months, obviously has been pushed back. It's whether or not we can fit this in with the Fit for the Future in the January-March meetings, or whether we could ask SWAS to give a short report or a short update. And there's also the review of the process for public representations that is sort of coming forward. I think we've been sort of in this now, or practicing this for nearly a year, coming up in January, which was going to be reviewed at a 12-month stage. So again, that could be something if you wanted to look at in November, just to see how that's going and if there's any suggestions for improvement. Becky, I'm not sure if you wanted to comment at all.
Yes, I think it's really sensible that we think about possibly bringing SWAS. Can you hear me? Is it okay? Yeah.
Yeah, we can hear.
Yeah, so it might be very short notice for them, so I think we could perhaps look to see whether or not they'd be able to manage that request. But obviously, it was delayed from September, so it is a while since the Scrutiny Committee has had an opportunity to look at SWAS activity and performance. The other thing I was going to mention is that obviously we'd like to bring an update to the committee about how the 2 consultations are going. Ordinarily, we'd include that within the Clinical Commissioning Group's Chair Accountable Officer report. Could do that as a separate item, or we could include that within the report and just make sure that there's sufficient time to discuss it when we discuss that main report. But other than that, I'm not aware of any other items that local NHS partners would want to bring to the committee in November.
Okay, I know Martin Forward wants to bring a topic forward. So Martin, if you're there, you can come in.
Yeah, I mean, actually, it links to both the progress of the consultation and the idea of talking to SWAS, actually. I mentioned in my remarks on the consultation that there was apparently film of 16 ambulances queuing up at A&E, and I took the advantage of the our brief recess to phone the news outlet, and it is indeed going to be there is going to be film released today of 16 ambulances queuing at Gloucester A&E on Tuesday. So this is on the back of obviously years of Gloucester A&E failing to meet its waiting time targets, of earlier reports in the year about long queues at A&E that appear to now have got worse since the closure of Cheltenham A&E for the temporary COVID measures. So I really think it's time that this was a main agenda item. I think it has implications not just for the urban areas, but obviously if the ambulances are queued up in Gloucester, they can't then improve their response times to rural areas as well. So these things, all 3 of them, link together, and it's important to know if we really have got the settled situation we were assured we had earlier on for the progress of the consultations, or whether actually we are in a bit of a crisis situation over A&E. And with the rising COVID cases, obviously we are expecting more hospitalisations imminently. So I don't think we can delay talking about this. And I think it would be great to have it at the same meeting that SWAS were present at.
Yes, I think what you really want to focus on the delivery of A&E, but linking it to the fact that ambulances may well be being held up unnecessarily because of the A&E process. Is that what you're saying?
The news story today will be 16 ambulances queued at Gloucester this week at one time.
All right.
So, I'm really happy that we respond to Martin's request and bring a broader paper, because I think the danger is that we focus on where the problem manifests itself, which is at the front door of the emergency department. Martin's quite right to describe the picture that we've got at Gloucestershire. It's a picture, sadly, that we're seeing up and down the southwest, and it's a combination of changes to patterns of demand, but also, unfortunately, as you know, in order to have a COVID secure environment, we can't bring as many patients into the ED as we could have done previously, which is one of the drivers. But very positively, we did secure capital funding for a modular build to enable us to expand the department. So that will happen hopefully before we get into the peak of either COVID or winter. But it's an entirely reasonable set of questions. I'd welcome the opportunity to further our collective understanding of why we get the ambulances queuing, because as I said, that's the end point of a very long chain of events that's about a whole system and some of the challenges we face across the whole system, including the health and social care system. So I think it might be helpful, Brian, just to think about how we might do a double act with colleagues in social care. As I said, it manifests in hospitals, but it's really not a hospital problem in its entirety.
Yeah, I think there's no reason at all we shouldn't bring a social care aspect into that, although they may feel they report that to adult care, but I'm sure we can work our way around that point.
Can I, Brian?
And I think
through you,
sorry,
Brian, if I could suggest through you, bringing social care into a question about ambulance waiting times at Gloucester is, I think, muddying the water. I realise there are certainly bed issues in Gloucester Royal that we need to perhaps address, but the key issue is the waiting times for ambulances.
Yeah, I mean, I don't share that view, but it does exemplify why I think it's very important that we discuss this next time, because there's clearly significant misunderstandings about why we're with queues and pressures in our ED. So let's not go there today. Let's come and bring the evidence, information. Let social care and my colleagues speak for themselves.
Thank you. I think where I am on that is if the answer to the question you're raising, Martin, involves social care, we might as well have them at the table so we can.
I don't think it does.
If it doesn't, then obviously it doesn't need to. So the suggestion is it may well do. So we'll pick that up. I know Steve Lyden wanted to come in as well, and I see Ellen is also indicating to speak. So I'll come back to it. So Steve first.
Okay, Brian. Yeah, there's one I've mentioned a couple of times. But we've picked up was the whole issue of health inequalities, which again are being brought to a head with the COVID crisis. You know, what are we doing to combat these? What actions are being taken short, and what are the plans longer term? I mean, it's not just a half-hour topic. I mean, I know today that the issues around B&E, for example, appears not to be down to race, to poverty. It's not, I don't know, it's somebody else again. That's one of them, Brian. And the other one, which has been lying around, and to be fair, none of us were involved in this last year, but I do think the committee needs to form a view on what its role and function is. And that includes the NHS colleagues, because unilaterally, to be fair, the county council decided last year to take away some of the responsibilities and put it into a new committee. So we no longer have the overview of public health and adult and social care. And certainly, I thought that was a retrograde step, but I'm not going to talk about it today. But I actually do think we need to talk about that as an item here.
Yeah,
that's two items.
You're right, and what I do know is that the county council has taken away the question of is the split of public health into adult care scrutiny the right one. So that is being looked at, and we will be looking at the outcome. I share your views, really. I think if you're representing your district on health matters, to then find that the bit that's talking about public health is on a different committee which you don't sit on, that doesn't seem adequate to me. I think in the short term, my view, and I know Stephen, the chair of the adult scrutiny, is in the meeting, but my feeling the short term way of solving that might be to extend an invite to those district representatives on HOSC to attend the adult one so that they can actually raise their questions directly, because the alternative would be to be having officers from public health coming to two committees, which at the present crisis time I don't think is a good use of officer time. But if we could actually extend an invitation to those district representatives so that they can come and attend and question on the public health one, I think that would mean at least that you're not sort of, as you say, disenfranchised from being able to do your job, which is to represent your district on health matters. So hopefully we can
Sorry,
sort
Chair.
that short term. Please go ahead.
Sorry, can I just, sorry, Brian, I didn't want to, we can have the discussion today, but I think it does deserve an item. Because I get what you're saying, but I do think that NHS colleagues need to be consulted. To me, it's about this committee being asked, rather than, no disrespect to the county council, but rather than the county council deciding internally and then informing us what it's going to do, I think we ourselves should have a discussion. That's all I'm saying.
Yeah, no, I'm agreed with that. I'm happy.
Could I just
I'm happy
come
to commit into that process. Yeah.
Could I just advise you that? Sorry, Martin. I'll just clarify. The county council will be doing a review of the situation, but this committee, HOSC members will be included in that review, so you will have your say. So, sorry, Martin.
Well, I was just going to say, I mean, it's not about the district councils having the chance to question public health. It's about the statutory health committee. I mean, the clue is in the title. We're a health scrutiny committee. We can't have a situation where there is no time for the director of public health, who deals with the health of the population of Gloucestershire, to come to this committee. I mean, this is just not acceptable, I'm afraid. We have a statutory role here, and we have to embark on it. So I think the item that Stephen has requested is right.
Yeah, no, that's fine, and I think we all accept that, but the county council does have a role in setting up all the scrutiny committees, and we need to go back and say, did they get it right? And we'll be involved in that process. Anything else? Oh, Ellen, you wanted to come in, I think.
It's slightly gone past, but given as it was quoted twice, I just wanted to offer a small point of clarification, because Martin has now said twice that I said that the health system was now settled regarding the COVID situation. What I said was that our approach and our response and our structures are settled in terms of how we respond. So we have our incident control process, we have all our one cells in terms of how we manage. We have our systems and processes in place for how we manage a surge or any wave that we have, how we flow between the beds and so on. Whereas in March, that was not the case. So we were having to, a bit like the kind of Wallace and Gromit film where the person's on the little train laying the track in front of them. We were in that situation in March. So we certainly didn't have the management capacity. So we feel more settled in terms of managing the ongoing response to future waves of COVID and the systems and processes we use as a health system. Not that the incident itself is settled, because clearly, you know, we continue to respond and we can see the second wave building, and we see that data every day. So I just wanted to clarify that because it was quoted twice and I didn't want that to be a narrative that people took away from this meeting. Thanks, Chair.
Thank you, Alan, for clarifying that point. I think now we've probably filled up all of the available space on our work plan, so we'll probably... Pam, are you trying to come in? No. Okay, right. Well, if we are at the end of the meeting, then I would just like to thank all the committee members for attending and contributing, all of the health board representatives for coming along and explaining things so well. And if anybody's been watching this, thank you for watching, and hope it was informative. So thank you very much, and we'll see you all at our next meeting.